run by organizations that are funded by and report to the LHINs. And we think that that needs to stop. So, you know, one of the unfortunate things about this plan is there are great people working in the CCACs. They've, you know, endured a lot of finger pointing. Toronto Star, the Auditor General, you know, that's unfortunate, realistically. They're great people doing great work. That great work needs to continue, but it needs to be expanded. Not just home care, home and community care needs to be part of what the LHIN's responsible for organizing. And the move of CCAC employees into the LHINs is something that's a crucial piece of this transformation. And from our perspective, the key issue is that on day one of the new system, whenever the switch is turned, every patient that's being seen by a home care coordinator on day -1 will be seen on day +1, and every check that gets cut to a CCAC employee on day -8 will be cut to that employee by the LHINs on day +8. That's an absolute commitment. The commitment to the labor unions that represent the workers in the CCACs, the commitment to those folks is something that we will start to explain in very clear terms after this period of consultation is completed. And that's probably the biggest commitment that we've got in terms of the short-term transition that we're planning. So those are 3 changes. LHINs changing their role with sub-LHIN regions, primary care being planned and performance measured and managed by the LHINs, home and community care becoming more coherent under the direction of the LHIN, and finally, possibly the thing that's most important in the long run is attention to population health. Now, you're about to hear an orthopedic opinion of what population health means. So I may have, Dr. Donnelly's in the audience, I may or may not get this right. But what my sense about population health that we're describing here is that currently we have 2 systems that run parallel to each other. We've got the public health system, we've got the healthcare system. We all know that the organization of the health system is not one of the key determinants of how healthy populations are. Far more important, income stability, far more important quality of food, far more important design of cities so that people walk rather than drive. All those elements are more important than organization of the healthcare system. But surely the healthcare system should be designed and planned with some understanding of systematic population health challenges that exist in communities. Surely those challenges are different in Sandy Lake than they are in the area that surrounds us here. And there are unique challenges. The Center for Research in Intercity Health has demonstrated. The map of Toronto, within Toronto, there are 3 Torontos that all have different healthcare challenges. And surely, as we plan the healthcare system of the future, we should have the expertise of population health to help us design the response of the healthcare system to the challenges of the population. Surely that's part of addressing the triple aim that we want to accomplish, healthier Ontarians as well as Ontarians that have access to a better and more cost-effective healthcare system. So Irfan, those are the 4 issues that are described in Minister Hoskin's discussion paper. We're in a period of consultation at this point that lasts till February 29th. Everybody in the room, I'm sure, has read it and is preparing an email response to our website that will give us advice about unintended consequences, where we're going too far, where we're not going far enough. We want to hear all those responses and bits of advice. After February 29th, we anticipate providing a pretty detailed roadmap of what the next year looks like. Nancy and her team are preparing the legislative changes that are essential to bringing this plan into reality. The implementation will need to take really strong account of people who are going to transfer their employer. Believe me, as someone who's participated in multiple hospital mergers, I know how important that is, to pay attention to people who are vulnerable because their employment is changing. To be very clear about what the impact will be on them, as well as on the patients they're serving. Having said that, I think what this represents is a new platform. It won't solve all the problems on day 1. It won't create a new system on day 1. But it'll provide us with a platform where all the people in this room who are interested in quality improvement will have a better place to expend their efforts, a better opportunity to influence the care that Ontarians receive, and most especially to reflect the title of this plan, which is to organize the system not around the providers, where we've been organizing for years. Nobody knows that better than me. To organize the system around what we hear from patients, putting patients first. So that's what we're planning. And Irfan, thanks for giving us a chance to do this, and look forward to your questions and advice from the audience. Thank you very much.
Thanks, Bob. You know, first of all, I guess I just want to say I think it's some really important points you made at the beginning about how there have been pretty substantial improvements in acute care over the last 10 or 15 years. And, you know, really we are, I think, blessed to live in a province where if you have a heart attack or a stroke or cancer or trauma, you know, your chances of getting excellent care really are very high. And also, if you want a primary care physician, you basically have one in Ontario now. You know, very small proportion of people can't find a family doc. So incredible progress over the last few years, and congrats to you, your predecessor, and your colleagues, in the ministry for those impressive accomplishments. And you know, at HQO, we love the sort of better has no limit philosophy. So, you know, we sort of applaud the direction of continued improvement and what can we do next. But I did ask, you know, folks who were here in the audience before, you know, what I should ask, and people said, ask the hard questions. So I'm going to ask some of the hard questions.
Very good.
The first is actually not one of my own, but it comes from Duncan Sinclair, who many people in the room will remember was head of the Health Services Restructuring Commission around the turn of the millennium, as you put it. And he has a blog on Anton's site, on the Longwood site, about the Patients First discussion paper, and it's generally a very positive and laudatory blog. But I'm going to pick the paragraph where he raises some reservations. So he says, "I do have two serious reservations about the wisdom of transferring to the LHINs operational responsibility for the current functions of the CCACs. The first is drawn from the experience with regional health authorities in other provinces, where it has become abundantly clear that mixing governance and resource allocation responsibilities with operational functions resulted in favored status for the in-house operational functions over those in the hands of other bodies, and B, a dangerous shift of focus from the longer-range governance functions of the regional health authority boards and managers to more immediate operational ones." So you talked, you know, these four sort of next steps. One of them was clearly moving CCAC functions into the LHINs. I just wondered if you had any sort of thoughts or response to those concerns raised by Duncan.
Thank you. No, I saw Dr. Sinclair's, he was kind enough to send it to me. Anton, I think, forwarded it to me. I appreciated that. Now, this is one of the comments that, you know, is the LHIN a contracting entity, or is it actually driving operations within the system? And I think when you understand home care and home care delivery, you recognize that, sure, there is some direct interface with patients that's achieved by home care coordinators. Are they now suddenly providing direct care to patients at the direction of the LHIN? Well, I think that's a little short-sighted. We need a place to employ 6,000 home care coordinators without creating another entity. You know, we don't want another entity. We didn't want more boards as the CCAC boards. We didn't want to put more infrastructure in place. The CCAC coordinators have been extraordinarily limited in their focus to being home care coordinators, home care organizers. They do not provide home care, as you know. The vast majority of home care in the province is provided by health service providers. Circle of Care, like the group that Sinai Systems is organized with, St. Eliz. We've got some wonderful creative home care providers in the province. That will not stop. On day plus one, coordinators will work for the LHINs, and they will contract home care for the LHINs through the health service providers that they were contracting home care with for the CCAC. So that doesn't change. It's not direct care provision. It is care coordination. Having said that, even though care coordinators will work for the LHIN, they aren't going to work in the LHIN offices. Where are they going to work? Well, they work right now. Where do they work? They work in Mount Sinai Hospital. There are probably I would bet, Joe, there are at least 12 home care coordinators in the Mount Sinai Hospital arranging post-discharge home care. They will start to work in primary care offices as they do now. We anticipate, as the RNAO suggested in their ECHO paper several years ago, they'll work in family health teams, they'll work in CHCs. So their place of employment where their T4 is issued will not serve as the place that directs their work on a daily basis. Their work will be directed by the service providers that they're working with. So I don't see this as a major issue. I think the expansion of the care coordinator role is an essential piece of what we'll expect to achieve as we talk about integration of home and community, and integration into coordination of roles, not just to the top 5%, not just post-discharge patients, but patients like patients having difficulty locating home and community mental health services, for example, is something that we hear needs tremendous coordination. That system needs to be more coherent, but it also needs more coordination. So we see the place of employment of coordinators for home and community care to be important. As I mentioned, our primary goal from this is to take the vulnerability of having the employer transferred for your work as being rapidly settled. You know where your employer is, you know where your manager is, but the role you're playing, the role that you're working on, will be defined by the people that you're working with, and we don't see that as being directed by the LHIN.
That's great, thanks. So some people have raised the question of whether there just is enough capacity in the home care sector. You know, whether when you read the STAR articles or the Auditor's General Report that you referred to, whether we just have enough resources in home and community care. And I know over the last, people in the room will know over the last few years the government has put in a lot of money into home and community care. But nevertheless, we hear these stories about individuals whose hours are cut, right? And then the response on the other side is, well, we don't have the hours to give. Where do you see that evolving over the next few years?
Well, one of the things that I'm really excited about this plan is that it's being implemented simultaneously with the 10-point plan. I know Gail's somewhere in the room, that Dr. Gail Donner, Gail's somewhere here. She's become a member of our ministry team. She gives us great advice. And that 10-point plan is something which is going to come into existence and impact on patient care at the same time as this transformation is happening under Nancy's team's leadership. It's very exciting, because what it says is, essentially, as we know, we've neglected home care for years. There have been a number of issues that have happened politically that sort of made it a bit of a third rail in terms of the kind of quality improvement that we've all participated in across most parts of the home care system, or most parts of the healthcare system. Home care was sort of under the radar screen, but Minister Hoskins and Minister Matthews before him recognized that if we're going to look after folks as they age, as they become more frail, as they lose their cognitive capabilities in the place where they want to live, in their home, that we need to really dramatically change the home care system, and that work is underway. So if you look across the province, there's really no standard in home care for how many hours you get, what kind of service provider you get, no standards as to when technology would be used to measure your physiologic functions as opposed to sending somebody in to check your blood pressure. There are all kinds of opportunities for improving home care, making it more cost effective, making it more reliable. Levels of care based on RISE scores, right? I mean, probably you can figure out most of what somebody needs by looking at their RISE score and who's at home with them.